We will now discuss the acute management of fistula. If you suspect that the lady has been in obstructed labour, has had a traumatic process in labour, or indeed if you see blood in the urine, you must catheterize always. The most likely trauma is typically to the bladder. In under-resourced settings, where catheters are not available, it is important to teach your community workers, traditional birth attendants, community midwives, hospital midwives, that this is a marker of a future problem. And a simple catheter left in situ may actually solve the problem. The morbidity associated with fistulas is so huge that in this day and age, we really need to use a simple plastic tube whenever we can. The other thing you must bear in mind is often in under-resourced settings, you're dealing with poor nutrition. So a lot of these young women have got anemia, have various vitamin deficiencies, and any help on that front would be very appropriate as it promotes healing. The third factor you must be aware of is infection. Not only infection to pelvic floor organs or the bladder, but general infections and the risks of conditions like malaria. All of these can be quite debilitating and have a significant impact in the patient's recovery from any trauma. One of the things we have come up with, and this is in tandem with our colleagues in other areas, has been the principle of pre-repair care, where it's performed at pre-repair units. Essentially, these are hospitals or clinics where they look over the patient, assess them, and promote their health before they put them forward for a suggestion of surgery. So, for instance, in this slide, it alludes to what I've already mentioned, the treatment of anemia using iron and folate supplements, the role of a high-protein diet, the treatment of any infections, in particular parasitic and malarial infections. If there are any signs of urinary tract infections or sexually transmitted diseases, these need to be also treated very well. One of the big problems a lot of the young women will suffer with is skin dermatitis due to the urine. They need to be supported in this and given instructions on perineal care and skin care, and we would also recommend the role of estrogen cream to help the healing of this area. It's absolutely critical that physiotherapy is part of their rehabilitative process, and it needs to be recommended from the outset. And more increasingly, we are looking at women's psychological and emotional support. After complete evaluation and explanation to the woman of her situation, which goes a long way in allaying the woman's anxiety, it's important to then discuss it with her and her family as to the next steps. We need to bear in mind that in under-resourced settings, women will need to travel to hospitals and centres where they will get access to surgical support and care. If catheters are put in, and if infection is treated, and if their nutrition is better, then some of them will heal spontaneously. Indeed, there have been studies in the last 2 years to show that 5% of even substantial-sized fistulas can close if these factors are taken into consideration. One of the areas that is increasingly gaining ground is counselling. Many women in the past would undertake surgery but not quite understand what was happening to them. Increasingly, both surgeons and all the support teams working with patients with fistula are recommending that the patient should be counselled, everything should be explained to her, and particularly complications. One of the issues with fistula surgery is the complications associated with it can be very life-changing. This needs to be discussed from the outset. It's also important not to promise the world, because very often these patients may not respond to surgery after one attempt. It may be after several attempts, and it may not always be successful. We need to mention to all of our patients that even if the fistula is closed, and this has happened in my practice and in the practice of my colleagues, there is always a possibility of residual incontinence, even though the hole per se is closed. We will discuss this in another film. There are other important things that occur, such as the risk of infertility, the problems with chronic pelvic pain, and the problems with chronic infections. All these need to be managed appropriately. Counselling the patient about surgery is very important. One of the fears that many women have is the possibility they may never wake up after an anaesthetic. Now, in under-resourced settings, many patients may have a spinal anaesthetic rather than a general. But increasingly, as patients are referred to bigger centres, general anaesthesia is part of the course. Therefore, it's important to explain to the woman that they'll be fine and all will be well. That's the most important thing, allay anxiety. The surgery itself usually takes about an hour, but in some cases can take 3 or 4 hours. So the patient needs to be ready for that. Although in under-resourced settings, the vaginal route is the preferable route, increasingly people are using the abdominal route because it gives you good access to some types of fistula and a better outcome for the repair. All patients will need to be put on antibiotics, and often most of the patients will be admitted to hospital for a period of 2 weeks. This is to ensure that their nutrition is maintained, their catheters are working well, and that they make a good recovery supported by the entire team. The big question after immediate procedures or assessments and preparations of women for surgery is, when do you actually do the surgery? There's no clear consensus on this, and I've certainly done surgery on certain patients much earlier than anticipated. But often if you assess the fistula and find it is really clean and the edges are well defined, with very minimal scarring, no bleeding and no infection, then my inclination would be to proceed to a repair. In patients, however, where that's not the case, then there's probably good reason to wait for at least 3 months to allow for all the tissues in the surrounding area to heal properly before you attempt a repair. Now on this slide, you'll see the reference to the Addis Ababa Fistula Hospital, which has been a very important hospital for developing some of the ideas and some of the surgical techniques we have all worked with. Indeed, I've been fortunate to be part of that team there, and we have been very instrumental in changing the way things are done. For example, some of the techniques that are now employed globally were developed at that hospital, and some of the strategies for managing the women were developed at that hospital. The longer the woman's repair is delayed, the more physical, social, and psychological damage there can be. Therefore, optimizing the woman for surgery should be a very, very important consideration, and people need to be aware of that all the time. This is a slightly more complex slide, but it gives you an idea of how fistula projects within the developing world and in under-resourced settings are working. Essentially, it's now become an effort involving everybody, from the community where the woman's from, to all the regional bases that can come in and support that community. Not only the health environment, but the social environment. And in some cases, you've got special women's institutes and women ministries that have come in to help the women. It's this integrated approach with actually working out what the woman needs, getting her to the right point of access, and ensuring she has all the support in place that has led to the fact that fistula is better managed today. A lot of regional and national hospitals are now working in close collaboration with different ministries, but equally with the community, with the women, and all their supporters and their mentors in getting them the right access to care. In summary, if you have a patient who you believe may have a fistula or likely to develop one, this is what you need to do. They need to have good lessons in perineal hygiene. They need to be well hydrated and have access to good nutrition. They need to be able to have access to estrogen cream, antibiotic support, and bowel management. Each country has a different strategy, but essentially it's improving the woman's situation, making her as well as possible before she undertakes some very radical and major surgery.